Hello, everyone. Welcome. My name is Rebeca Melendez. I am with the East Los Angeles Women's Center. And thank you. And I'm a community organizer. And I say that because I am not an IT person. So this this session is live and virtually, and that means that I'm going to have to navigate between all screens and all of the sharing. So I ask that you please be patient while we maneuver and manage all of this. Additionally, I want to introduce Virginia with Futures Without Violence, who is the voice of reason. She's going to be monitoring our online chat and the questions. And with that, we can get started. Today, we are going to be hearing from some amazing leaders in our work. And this is where the IT part comes in, so bear with me. Window. Ha. Oh, maybe I am an IT person. Here we go. Yes. First obstacle overcame. This is exploring innovative partnership models to improve survivor access to quality care. Our speakers today are Melinda Cantu, Ashley Starr Frechette, and Amanda Gould. I'm going to share with you a little bit about them. Their full bios are available within the list of the sessions. Let's see. So Melinda Cantu has been, Melinda Cantu has been a part of SAFE for more than 30 years in both direct service and leadership positions, beginning as a volunteer at the Austin Rape Crisis Center and as an intern at the Center of Battered Women. She has since implemented many new programs for youth and adults at SAFE. She is considered an expert in operating barrier-free shelters and services and has presented both nationally and internationally on this topic. Melinda believes in the inherent capacity people have to change their lives, especially living safer lives. She and her staff work with survivors to ensure that any violence or abuse they might have experienced does not ultimately define who they are, but makes them stronger. Ashley Frechette. Ashley is the Director of Health Professional Outreach at the Connecticut Coalition Against Domestic Violence. She has her master's in public health degree from Northeastern University. Ashley educates and trains health professionals across the state on intimate partner violence, screening, intervention. She oversees the Health Professional Outreach Advocacy Program and various health collaborations. And now Amanda. Amanda Gould is a Senior Program Manager of the National LGBTQ Institute on Intimate Partner Violence at the Los Angeles LGBT Center, a project with the core mission of improving our country's response to the unique needs of LGBTQ survivors. Amanda has been supporting survivors of sexual assault and domestic violence for nearly a decade, working in the field as a survivor advocate, crisis responder, case manager, support group facilitator, forensic exam advocate, and violence prevention educator. Now, we are going to have all three guests tell us a little bit more about their programs and about their roles within these programs. And I'm going to be managing the power of the screen here. So again, bear with us as we do this. First is Melinda.
Hello, everybody.
Perfect. Great.
Thank you so much. And so I'm gonna ask you, are you gonna switch slides for me?
I'm going to switch slides for you.
Thank you.
Slide or next, whatever works for you. I'm here to work with you.
All right. So my name is Melinda Cantu. My pronouns are she, her, ella, and I am with the SAFE Alliance. And actually, very recently, we had some organizational shifts here at the SAFE Alliance. And so I had been a vice president over programs, and now I'm one of two chief program officers at the organization. I actually started, as was mentioned, years and years ago doing this work. I tell people I was 2. I was just a teeny tiny baby back then. But I am amazed at the survivors that I've had the privilege and honor to work with, and I am so excited to be here with you to talk about thinking through beyond our silos in this form. Next, thank you. So just a little bit more about the Safe Alliance. Yeah, our mission is our name. It's Stop Abuse for Everyone. And what is amazing about that is that my heart and soul is children and women's issues. And so when I started at the Austin Rape Crisis Center, the work that I did, I realized that young people and working with young people and having these two things come together would be something that I'd want to do forever. So the agencies merged around me. So I was able to really do the hard work that I wanted and learn and grow. So we are a merged organization. We serve domestic violence, sexual assault, human trafficking, and child abuse survivors. And we are a community-based nonprofit in Austin, Texas. You can go to the next slide, thanks. So our vision is a just and safe community. And here's the deal, a long time ago, we learned kind of the hard way that you cannot do this work by yourself. You cannot do this work in silos. You have to do it with others. You have to partner. And so we were very strategic in building alliances and relationships and shared understanding with systems within our community, education, healthcare, justice systems, housing and homelessness. We realized that the survivors that we worked with were telling us that they needed our voices and they needed their voices in these spaces. So we have now about 80 different collaborative relationships across the city and counties so we can serve these survivors. Next. So we do this work and we acknowledge that there's intersections and different types of abuse and oppression. And really what we have learned, what I have learned is that you can't do it just in a silo of intervention. There has to be prevention, intervention, and then what we tend to do is look at long-term change and what we want for the future. So just a little bit more about just history so I can tell you a little bit about what's going on today. So the next slide, please. We started in the 1970s. So the Austin Rape Crisis Center started in 1974, and then the Center for Battered Women in 1977. About the mid-90s, our community came to Austin Rape Crisis Center, it's ARCC and CBW, and said, hey, you all do this work. You do this amazing work. Do you think you could do it together? And so in the mid-90s, we merged and became Safe Place. In 1984, the Austin Children's Shelter for Infants and Children started. And then in 2017, the Children's Shelter and Safe Place merged to become the Safe Alliance. And the reason that we did that is that we saw the continuum of violence and abuse happening with all people, children, men, women, all ages and races. And so what we wanted to do was really think through how to be the most effective in order to enact long-term change for people in our community. And so that's what we did. In 2017, we became the Safe Alliance. Next slide. So just a little bit about our services today. So we have an organization that has over 30 programs, as I mentioned, prevention, intervention, and then long-term change and social change. We do this with about 400 staff. That's a lot of staff in the now times. Staffing, the crisis, there's that. And then we have everything from a safe line with calls, chats, and texts, all the way to programs that provide long-term housing and supportive services. And we serve about 6,000 people every year. And last year, I believe we had about 21,000, a little over 21,000 people reach out to us on our Safe Line. And that's me.
All right. I will go next. My name is Ashley Starr Frechette. I'm the Director of Health Professional Outreach at the Connecticut Coalition Against Domestic Violence. Thank you guys so much for having me. Here I run the Health Professional Outreach Program, which CCADV is our state's leading voice for victims and survivors and the agencies that serve them. So if you go to the next slide. Well, in the meantime, oh, thank you. So here in Connecticut, we have 18 member organizations that are under the umbrella of us at CCADV. So our 18 member organizations serve victim survivors and then agencies in the area that are wanting to support those individuals. There's no area of the state that's not covered by one of our 18 member organizations. Through each of our member organizations, we have counseling services, support groups, we have our emergency shelters, we have court-based advocates in every single one of the courts here in the state of Connecticut. We have the option for safety planning for children and adults. And we have what's called the lethality assessment program, which all of our police officers across the state utilize when responding to a domestic call through 911, where they assess the individual who would be the dominant aggressor and then the individual who is the victim survivor, and then connect them directly to our member services. We also obviously have education and training like I'm doing now. So our staff at CCADV is small, but I would say mighty, that oversees all of these 18 members. We have a director of law enforcement, a director of housing, we have a director of diversity, policy, training, and then myself as the director of health outreach. And I oversee, some of our 18 member organizations have a dedicated outreach advocate who I oversee to help provide resources to the health providers in their area. Next slide. And in the state of Connecticut, we have one statewide hotline. We used to have 22 separate ones for all of our separate agencies, but we have one statewide hotline, which is called C2 Safe Connect, which is also housed at our main organization here. So just to give you guys a glimpse of what we do here in Connecticut, last year we ended the year serving almost 39,000 victims and survivors, and this was an increase from the prior year. Our shelters tend to always remain at about 50% children and 50% adults. We've remained at about 156% capacity all throughout the past year. It was a little higher the year prior due to COVID. And we ended our year last year with, unfortunately, 11 intimate partner violence homicides. Those range from age 21 to age 75. So we really try to emphasize the fact that abuse affects everyone, every age, every socioeconomic status, every sexual orientation, you name it. There really is no discrimination in that area. If you go to the next slide. So through our member organization at CCADV, through my role as a health professional outreach program director, we try really hard to engage health professionals across the state by giving them information on what I kind of just talked to you quickly about today, letting them know, how this affects Connecticut, how many people are being served, and offering free trainings that can help support individuals to understand the basics of IPV and then also what they can do to support their patients and clients. We train our member staff as well to support and connect with local providers so that they can have that hands-on connection to feel supported. We work with state agencies to highlight IPV as a public health crisis so that we can create policy change here. And we create and provide IPV resources at care settings across the state. So trying to collaborate with people on what works best for them and how to best support their patients and clients. We also offer free and flexible trainings with the ability to have CEUs or CME credits, which really helps to get more providers to the table. And we've been able to participate and run different ECHO programs or IPV certification collaborations within healthcare settings to help expand advocates, not just at our organizations, but within the healthcare system as well. And this has been really helpful in certifying medical staff as actual IPV advocates on site. And I'll hopefully talk to you guys a little bit more about that today. If you go to the next slide, that's my contact information, and I look forward to our conversation. Well, in the meantime, I can just verbally tell you that my contact information at CCADV is, I'll put it in the chat actually because it's easier. Perfect. That's my contact information. If anyone has questions after this talk, please feel free to reach out. We're always looking to collaborate and discuss with others. So thank you for having me.
And let us get to your slides.
Take your time. Can folks hear me while that's getting set up? Okay, thank you. I see Melinda has a thumbs up. So okay, wonderful.
Amanda,
well, hi.
go ahead.
Thank you so much. Very excited to be here. Thank you so much for having me. Hi, everyone. My name is Amanda Gould. My pronouns are she, her, and they, them. And I'm the Senior Program Manager at the National LGBTQ Institute on Intimate Partner Violence, which is a project of the Los Angeles LGBT Center in partnership with National Coalition of Anti-Violence Programs and In Our Own Voices. If you could go ahead and go to the next slide. So as you'll see on this slide, what we've got here is lifetime prevalence of intimate partner violence across demographics. So on the left, you'll see these two bar charts are based off data pulled from the CDC on bisexual men and women, gay and lesbian men and women, heterosexual men and women. And on the right, we have results from a survey done by the US Transgender Survey on lifetime prevalence of IPV amongst transgender people. And what these studies have shown us, along with other studies done on LGBTQ IPV, is that LGBTQ people experience intimate partner violence at higher rates than non-LGBTQ people consistently across the board, with bisexual folks, transgender individuals, and BIPOC LGBTQ folks disproportionately impacted by intimate partner violence. Yet, unfortunately, what we don't see is these demographics represented in who's coming into the doors of supportive services, whether that's domestic violence supportive agencies, whether that's medical interventions, whether that's law enforcement and more. LGBTQ folks overwhelmingly aren't coming in to get the supportive services that they need. And when they do, oftentimes are met without culturally responsive care, which can be a real barrier. If we could go to the next slide.
Amanda, while your slide is being switched, I just want to remind our speakers that we do have very gifted and talented translators who are translating, and they want us to pace ourselves so that they can keep up with our Spanish.
Yes, absolutely. I am a fast talker, so I appreciate that reminder. Well, that is where, reflecting on the last slide, this is where we come in at the National LGBTQ Institute on Intimate Partner Violence. Our overwhelming goal, our overarching goal, is to improve national responses to LGBTQ intimate partner violence. And we do this through a myriad of different ways, but predominantly through these three strategies we have here on the slide, which is training and technical assistance. Is we want to improve public and private agencies' capacity to better serve LGBTQ survivors. So we focus on two main audiences here, which is domestic violence service providers and LGBTQ social service providers, but we're also trying to spread across other different sectors with the overall goal that there's no wrong door for LGBTQ survivors. So we focus these trainings and technical assistance on language and terminology that's culturally responsive, the unique and specific issues and barriers that LGBTQ survivors face, and skills building around how to better support LGBTQ survivors. And then we also provide one-on-one technical assistance with agencies to look at their policies, their procedures, their day-to-day interactions with survivors to see how they can better support LGBTQ survivors in a specific way. We also provide resources and best practice guides on our website. And these are for all different types of providers. They're for medical care providers, they're for therapists, they're for domestic violence service providers and more, to really make it easy to have in your hands tangible resources we can provide to LGBTQ survivors. And we have all different types of resources, but I'll highlight one that we recently published, which is on the intersections of human monkeypox and domestic violence. For those who don't know, the first case of human monkeypox first occurred in the US this May, and since then has skyrocketed in cases across the country, and disproportionately it's been impacting LGBTQ individuals. So we have a resource guide on best practices for service providers of all types to destigmatize the conversations around human monkeypox, provide accurate information for survivors to be able to access testing and treatment and vaccination, and also to work with survivors around unique safety planning and safety considerations and financial vulnerabilities that might occur from human monkeypox. And lastly, policy advocacy. We're looking at political legislative efforts on local, state, and national level. So anything that impacts the well-being, health, and safety of LGBTQ survivors of intimate partner violence. So of particular interest to this audience, we recently spoke in support of a California state bill, which would change mandatory reporting requirements so that medical care providers would not have to report to police when a patient discloses domestic violence, and instead can make a warm referral to a domestic violence service provider. This impacts all survivors' safety to have non-consensual police involvement before they're ready, but for LGBTQ survivors who disproportionately face discrimination and violence from the police, this is of particular importance. So that'd be an example of policy advocacy that we do. If we could go to the next slide. So what do next steps look like for you all? We're going to be talking more in our panel discussion about ways to improve LGBTQ cultural responsiveness and capacity to better serve LGBTQ survivors. But what can you do after that? We offer 2 different types of trainings. We offer a 2-hour core training for agencies that specialize to your agency's needs on cultural responsiveness and skills building around working with LGBTQ survivors. We offer a 5-hour advanced capacity building training that can be broken up depending on the needs of your agency. We offer one-on-one technical assistance where we can take a deep dive look at your agency's policies, procedures, practices, materials, and support your specific agency in improving LGBT cultural responsiveness. And we also have an ongoing learning center. So in addition to the resources you'll see on our website, we're going to continuously post topic-specific trainings. So for example, we have an upcoming training that will be on the unique and specific sexual health needs for LGBTQ-specific LGBTQ survivors' specific needs. And we'll be posting that to our website. I see that the moderators have exited our chat here. So they might be having some technical difficulties. Melinda and Ashley, are you seeing the same thing? Okay, well, we'll wait for them to join us. In the meantime, I'll just plug in the chat. I'll drop the website, my email address, if you want to get in contact and get your agency connected with these next steps. That was all that was left on the last slide, so I'll just pop that in the chat for our audience that is virtual.
Hey, we're back. I'm so happy to report to everybody here and at home that the PowerPoint presentation is over. So we can now have a conversation. And I'm actually really excited about this conversation. So I guess it's almost 9 years ago, I to the intersection of domestic violence and healthcare, and not knowing very much about the intersection outside of the fact that we as community-based organizations respond to the hospitals. It was very enlightening and intriguing to me to learn what that partnership should look like, and more importantly, could look like. So when we designed this session, it was with the hopes that we would have some providers and some community-based organizations as part of the audience, and these experts, because there's very few throughout the country who are actively doing this work, that these experts would be able to give you insight on what creating a partnership could possibly look like for you and in your communities. So let's see here. I have a series of questions, and because I do this work, forgive me if these questions may be self-serving, but I'm going to take full advantage of who I have on the panel to be able to further our work and better serve the survivors, and more importantly, create those partnerships with the medical centers in our community. So my first question is for Melinda. What are examples of coordinated relationships you have made which have created long-lasting positive impacts on survivors in your community?
Really good questions, Rebecca. Thank you. So we've had several, and one of the most important, and I dare say life-changing for survivors of sexual assault, is a forensic nursing and advocacy program that literally came as a result of survivors' voices, survivors who are coming to us and saying, we're waiting too long in the emergency rooms, we're paying too much when this happens, I'm not going to stay here anymore, I'm not even going to go through this process, this is the worst day of my life and nobody is helping me. And so really listening to them. Here in this community, we pulled together and had a sexual assault resource and response team that pulled together law enforcement and medical providers. At the time, there was a specific organization that was providing the forensic nursing piece, and we were providing the advocacy piece to survivors of sexual assault. And that team dream, they had a dream. And the dream was that there would be another place where survivors could go instead of an emergency room or a hospital, and they could get the services that they deserved in a trauma-informed, supportive way so that they could start to get the care that they so deserved and not have to answer 5 million questions from police officers. So, and all of the other things that happen when you have to wait in an ER. So we were able to actually have a program, a stand-up program on site where our shelter is. And it was a choice for many people. They could always, by law, go into any hospital, into an ER, and get served. But we now have trained forensic nurses and advocates working together, and survivors can come on site and they don't have to pay and they don't have to wait. And it is so beautiful and it is so amazing. And it took us really talking and raising up survivors' voices in order to do that.
And I think when I hear you say that, what comes to mind is I feel, and when we talk about silos, right, I feel like you speak to medical professionals and they tell you what the need is for their clients. You speak to specialty organizations that work with survivors of domestic violence, sexual assault. We know exactly what it is that's going to work for survivors. So my question for you, Ashley, is how do you sell the value of your partnership to the systems and get them to buy into what this partnership could look like? And then on top of selling them the partnership, how do you go about securing the funds to get this partnership off the ground? Because everybody has the best intentions, right? So how do you, it's a double-edged sword. Sometimes you can convince everybody that you need to have this in place, but then the next thing is we don't have the funding.
That's a great question and something that we definitely deal with on a regular basis. But thank you for bringing that up. I think one of the biggest things that we do here in Connecticut and that has been successful for us is we try to be pretty relentless on the ground trying to get connections. And many times we just try to start with a free training and cater to their needs by offering the ability to have the CEUs and those CMEs. The way we've been able to do that is by harnessing the ability of major hospitals have usually a CME team, and they usually are willing to offer the cost of those CMEs in exchange for the education that you're going to provide when they need that. So that's been a great way for us to get in the door and then also to be able to give people what they need to keep their license. So We also have found benefit in giving a small stipend to our member organizations through our IPV organizations to at least start that collaboration with our local health agencies, just by applying for small grants or trying to use small amounts, just as little as like $1,000 to help support their time for a little bit. And many times that collaboration and that partnership that they gain continues to go on without any more need for finances. So being able to spend those small funds that we do have or use resources in the community that will be willing to help us get tear-offs or posters, things that we can help to like keep getting that information out there and help people feel like they have something they can show to their patients has been really exciting. And then moving forward, it seems like money starts to be less and less of a problem because that buy-in is there from putting that initial time in with the little funds that we do have, but trying to just keep offering any type of hand-holding as long as we can.
And, I think one of the things that is easier is convincing the medical teams to come on board because they understand the value of having our expertise represented and what that means for a survivor. I suppose if I wanted to kind of dig into your question a little bit is how do you get administration on board? The administrators, any of you are in the room, the administrators are the ones that can make or break our initiatives. So how do you get them on board? Because the providers, they're in it. They've bought in. They understand. They've seen us work. But the administrators sometimes are the ones that can push back. So if I were watching this and I wanted to pursue a relationship with a local medical center, how would I approach administration? Anybody?
I can follow up on what I said already. Sorry, I should have put that into my original answer, but yes, administration is really where it makes your job a lot easier if you can get someone at that level. One thing that's been really successful for us is joining a lot of like governors' councils or government task force to get our word out with those bigger higher ups that maybe are in that realm. And then also, I've even done instances where we've been able to get a word in and sat down with administrative offices, and we've asked them to look through their records on any of the news articles they've seen on TV or any of our homicides. Many times they have those patients have walked to their doors at some point, and a lot of times that's a turning point for them. Or one major thing that's been really helpful is I ask a lot of them how we have tear-offs in a lot of our bathrooms, and throughout hospitals we encourage them to do that. And throughout COVID, many of them had no visitors at all, yet the tear-offs were going at the same rate as when they had thousands of visitors a day. So really getting them to recognize this is also a problem that their staff deals with, and to support their staff, they need to take this leap. So that's where we've been able to get our in.
So I guess, Amanda, my question is for you. We have the perfect scenario, right? The community-based organizations are on board, medical providers are on board, administrators are on board, and then comes Amanda. How do you explain, how do you convey to the medical center the importance of including and creating a program for the LGBTQ plus community that is equal and offers the same opportunity, resources, and access that is often offered to everyone else?
Thank you so much for that question. I think it's really critical that we look at domestic violence, LGBTQ bias and discrimination, and the needs of LGBTQ intimate partner violence survivors from a health equity lens. We know that and I know this room knows, that there's a host of negative physical and mental health outcomes that come with trauma exposure, right? Chronic lung disease, heart disease, cancer, STIs, depression, mental health conditions, and more. And we also know the same is true for folks who experience bias and discrimination. LGBTQ people are shown to have higher rates of being denied medical care, are less likely to have health insurance, are more likely to experience discrimination when seeking medical care, have higher rates of substance use and abuse, higher rates of eating disorders, higher rates of breast and cervical cancer, and more. So we know LGBTQ intimate partner violence survivors have a higher rate of long-term health impacts and term health impacts. So framing this as a health equity issue is really critical. Even looking at COVID, we know that domestic violence survivors are more likely to experience long COVID symptoms. We know that bisexual and transgender individuals have been more likely to experience long COVID symptoms. So it's critical that we're taking extra care, whether you're coming from the domestic violence service provider lens, the medical care service provider lens, or social services or more, that we're taking extra care to link LGBTQ survivors to healthcare resources, including COVID testing and vaccination, treatment resources for COVID, healthcare clinics, talking about sexual health needs that are unique and specific to LGBTQ survivors, right? We talk about reproductive coercion a lot. Let's expand that conversation out to talk about sexual health coercion for LGBTQ survivors. And so being able to frame this in a public health lens is so critical, and connecting LGBTQ survivors to health information, testing and treatment, and the care that they need before health conditions worsen.
And so have you come across any resistance? Can you give me an example of how if so, can you give me an example of how you address that? If that required policy change, what did it require for you to go in? Because I know in general, right, just walking in the door, there's a lot of education, there's a lot of provider support that has to happen, and having a specialized area is one more step. So what does that look like when Amanda walks in the room and says, okay, you guys got the domestic violence 101 down, you know how to identify a survivor, right? But wait, there's more. So what does it look like? What would policy change look like, or what has it looked like?
Oh, yeah. Policy change is huge, and I'm so glad you're talking about that. And talking about the buy-in piece too. I think one part of the resistance has to do with the fact that this movement has a beautiful history. I've been in domestic violence service provision for 10 years, and we come from a feminist standpoint, a women empowerment standpoint, and we name the fact that patriarchal violence and oppression is used as a tool of abuse, and we name the fact that sexism is used as a tool of abuse, right? But we can also name those things and make space for the fact that not only women experience domestic violence, and domestic violence impacts people of all genders and sexual orientations. So talking about, sorry, there was a little bit of background noise. So talking about how to have these conversations with LGBTQ, about LGBTQ survivors with domestic violence service providers or medical care, I think it's helpful to look at all the barriers that come for an individual to access care in the first place. As we know in this room, particularly domestic violence service providers, what it takes to come forward and seek help and all the barriers. So let's, take, for example, a hypothetical survivor who's a transgender woman. And she has to overcome the barrier of the fact that LGBTQ IPV doesn't have representation, and even identifying her experiences IPV takes a lot. She has to overcome the barrier that maybe she's disconnected from her biological family and doesn't have family to turn back to and stay with. She has to overcome the fact that leaving an abusive relationship might mean losing her tight-knit LGBTQ community that her abuser is also a part of. She has to overcome the fact that her abuser might be threatening to out her if she leaves. So she overcomes all those barriers on top of all the barriers that domestic violence survivors face towards coming forward and seeking support. And what is she met with? She's met with a therapist who misgenders her and asks invasive questions about her identity. She's met with a shelter that says, no, you don't meet our definition of womanhood and you're not welcome in our shelter. She's met with a police officer who doesn't take her situation seriously because she's transgender. And this is impossibly cruel for LGBT survivors, but it's the reality across the country, is LGBT survivors face not only the barriers that they're facing towards leaving an abusive relationship and accessing safety, but so many systemic barriers in these systems that are supposed to be there to protect them and support them and help them seek safety and healing. So that's how I try to frame this, is we're all about reducing barriers by increasing cultural responsiveness and looking at the unique and specific LGBTQ issues that survivors face to provide more culturally specific and specialized services.
And I can only imagine that that's a lot of organizing of trainings, a lot of organizing of cross trainings, So Ashley, can you share with me what you believe is the benefit of cross-training between the teams and the partnerships? There's a lot that happens on the medical side that we as advocates don't know about. There's a lot that happens on the advocacy side that medical providers don't know about. So is there a benefit to us cross-training? And if so, can you share what your thoughts are on that?
Yes, thank you. That's a great question and something that I think we're really proud of here in Connecticut, was taking that leap to work with medical providers and our member organization advocates to sit at the table together and, understand that we don't know or don't speak necessarily the same language as the other. So really trying to support each other, getting to know each other, to come to that common goal of supporting survivors. So one thing that we've found really successful is the ability to cross-train through using things like echoes or offering a bi-weekly meeting where we've done this with community health centers, where we try to take a number of their staff, whether they be nurses or medical assistants, and then a number of our local member organizations that coexist with those organizations based off their towns. We have them sign MOUs, and then we meet on a bi-weekly basis and connect on the basics of IPV for the first few weeks, and then go through some examples and talk through those each session. And then the next couple of weeks, we have them lead the sessions and talk to us about their programs that they might have that could benefit victims and survivors. And then by the end of this collaboration, we have the idea of who actually this person is, and then we many times will then set up in-person meetings with each other's local organizations to make the next steps, where we've actually been able to bring mammogram vans from their medical sites to our member organizations to support our survivors, and then take our survivor resources and bring them directly to their medical site to support someone who might be in crisis. So we've really found success in taking that opportunity to sit down and take those, bi-monthly or monthly opportunities to share resources and educate others on what we tend to see as sometimes being a barrier.
Okay, Melinda, so we have the perfect scenario. We have a willing partner in a community-based organization. We have a willing partner in a hospital-based setting. Everybody's on board. What does the ideal model look like? What are some innovative ways that we can come to the table? How do we exchange information? How do we meet the needs that are truly serving survivors? Because we can go in and say, oh, we're all doing such a great job, right? And all of our trainings can be in place, but how do we translate our theory, our trainings into actual impact that is reflected in our community through the faces of survivors? No pressure.
You have such good questions, and it is not easy. So you have this beautiful, everybody's at the table. What Ashley said, we actually have to not only do cross trainings, but it is joint goal attainment. What is our goal? And to have buy-in from all of those parties and partners. I used to say collaboration. It's so much work. It is so much about building relationship and building trust and honoring the experiences and information that each party stakeholder brings, and then having a shared goal, and then finding the money. Finding the money, and truly, in our community, we were able to tie high-end users in emergency rooms and really look at homelessness and what's happening in our community, and identify that many of those people were trauma, violence, and abuse survivors, and then we got a seat at the table. So we got a seat at the table, and I always say, you don't do anything about us without us. when you talk about survivors, because their voices are the most important, their experiences. Because I can, 30 years in, I'm like, it's different today than it was back then. I want to know the real deal, because that's what's going to make the impact.
And I feel like one of the most common questions that I hear in our work is, do you see the difference in the work that you do now as opposed to 20 years ago in a hospital-based setting? And all three of you have vast experience. So that is my question. Do you see the difference when you are approaching providers, when you're approaching a partnership, in the reaction and the understanding of why this partnership is valuable?
My answer is 150% yes. Absolutely. Absolutely. And I do believe it's part of that real acknowledgement of people with lived experience, and making sure that you have their voices at the table, and making sure that you are really, really listening. But it totally different.
And now that we've painted a perfect picture, I want to hear about some of the challenges and the struggles that maybe you've had in building these partnerships. Because again, it's everybody's on board. We have all the money in the world. The survivors are all happy, but that's not real. What is some of the struggles, and how have you overcome some of those obstacles? Amanda, maybe I feel like that's something that maybe you can speak to a little bit.
Yeah, absolutely. So to answer your earlier question, yes, I do think that the movement is moving towards including LGBTQ survivors so much more in the conversation. It makes me so happy to hear, but there's definitely a lot of room to grow. Some of the things I can think about as like easy steps towards moving into a direction of LGBTQ IPV inclusivity would be, there are some simple steps that a lot of medical care service providers, domestic violence service providers, social service providers can take, such as including sex orientation, gender identity, and pronouns on intake forms. This is a really critical way of cueing to your patients, your clients, your survivors that you're working with, hey, we are an LGBTQ responsive organization. By showing that you have best practice language on your intake forms, you're giving that visual cue to the folks coming into your doors. But it also cues to the provider, to the advocate, hey, I need to take extra care and consideration to be providing LGBTQ culturally specific resources and information, and make those healthcare linkages like we're talking about. LGBTQ survivors disproportionately face negative health outcomes. And on the back end, it also allows an incredible source of data collection, right? We can look at, are LGBTQ survivors accessing certain kinds of resources or not? Why is that? What might some of the barriers be? Are LGBTQ survivors being accepted, having their restraining orders accepted at the same rates as our non-LGBTQ survivors? Are we having LGBTQ survivors coming into our clinic at the same rate as we know is characteristic of the population? Are we missing the mark here? And displaying LGBTQ specific information and resources is another really powerful visual cue. Making sure your brochures, your posters, your website, your language used on a day-to-day basis isn't using gendered language, not making assumptions about the gender or pronouns a partner uses. There are some really critical and easy steps organizations can start taking towards just increasing the visual visibility of LGBTQ survivors. And we do see that whether it's a clinic, whether it's a DV service provider, once you start making those changes, you do see more LGBTQ folks coming in your doors. You do see LGBTQ folks feeling safe and comfortable to share parts of their identity with you. And what a transformative difference that even just those simple stepping stones can make.
Thank you, Amanda. Ashley, how about you? What obstacles have you seen along the way, and how did you overcome them?
Thank you. So we see obstacles, I would say, on a daily basis, but the majority of those being that there is a general lack of education and resources for providers around IPV and how to respond. In school, they don't get nearly enough, immersive education on what to do. And I think there's that panic of, what do I do if someone discloses? Am I going to make this worse? What are my mandated reporting opportunities? Things like that. So I think what we have been able to do is walk into every training and just, reassure all healthcare providers that you do not need to become an expert on IPV. You have enough to do. But these are the resources here in our state, and they are there for you just as much as they're there for victims and survivors, and really offering that kind of hand-holding option and really emphasizing what our mandated reporting requirements are in the state, and walking through examples, because many times I think that's a big barrier that people are afraid of, and just say, you know what, no, I'm not going to talk about this topic because I would rather not deal with that issue. So really trying to, number one, get buy-in that this is something important. And I think the second biggest obstacle that I encounter is many times larger organizations will tell me, I don't see this as necessarily beneficial to our financial well-being, because we don't necessarily have programs for IPV. So they're not always willing to step out and support it. But the more I think we push and highlight what some of the smaller health centers are doing, it helps people kind of get put on a pedestal, like, okay, these other sites are doing this, so now what can we do? And recognizing that they do have 1 in 4 women and 1 in 7 men that are walking through their door. And pretty much everyone they're treating has been in a relationship, will be in a relationship, or knows someone in a relationship. So why not take that opportunity to support those individuals?
Thank you, Ashley. Melinda, can I get some thought around this? I really am interested to hear the obstacles that you've come across and how you overcame those obstacles.
Truly, when you think about, community-based organization and coming from the work that we have done, and really trying to support access and health equity for survivors. The thing that you need to know about me is, if one door closes, I'm gonna go knock on another door. I mean, like, they're absolutely, you're gonna get the door slammed in your face, and you know what? That's okay, because I'm just gonna go to the next door. And I'm going to do it because I know it's the right thing to do, because I know it's in the best interest of everybody, not just survivors, but of our community. And so, glass is always half full, and you just knock on the next door.
Yeah, I agree. I always tell the story about when the East Los Angeles Women's Center began providing response services to the Emergency Department for Domestic Violence Survivors. The advocates were trying to just strategize and come up with a way to be able to present our value to the social workers. And when we started to knock on that particular door, they literally opened it up, and they're like, we heard you were going to be moving on campus, and we're so happy that you guys are here, and you're such a value. And I think that, finding the allies on campus has been, for us, the greatest opportunity, the greatest gift, and the greatest support. Because we speak the same language, and we understand that the end result is to be able to help that survivor take the necessary steps that they need to make for their lives to be able to access safety. But not everybody is receptive to that, right? Not everybody is opening their doors and, just literally, some of them bake cookies for us during the holidays. So we have an amazing relationship, but that relationship has taken years to build. And so, Ashley, my question is, how have you coordinated relationships so that they last? Because turnover happens, people retire, people move on, people get burned out, What has been your secret in managing those relationships with the department as well as individuals so that they are sustainable?
Thank you. That's a great question, and pretty much something we try to balance every day. one thing I would say that one area where we've really tried to keep a sustainable relationship has been in the OBGYN field. One of our biggest organizations here is called Women's Health Connecticut, and we worked, like we all said, we worked years to get them to listen to us and want to, we found that one person who had that buy-in and had enough pull, and use that person to leverage that ability to work together as an organization. So we offered like a lot of our time to this organization to say, hey, we will help you implement screening questions that are comfortable for your staff. We'll do focus groups. We pretty much stood there as hand holders to go walk them through the full implementation of a new screening and education process, to ensure that all of their patients were going to be screened and educated on IPV. And once we started to do that, it kind of snowballed into this, like I didn't have to put as much effort as I thought I would, because me just being there as a hand holder for them or offering as many handouts, printouts that they needed, just being that hand holder for them has been so amazing. So what we found is in that first year of that collaboration, people didn't see much change. So I kept trying to push, why this is important. And that second year, I started to see all of it turn around, where they started to see more disclosures. They started to have staff coming out. And through that, we worked together. So what could we do better to support you? Because we had a lot of patients who would disclose, but then recant, because why would I tell you this? And why would I call a random hotline? So what we've been able to do is sit with their full team and our full team and talk about, could we train your staff to be certified IPV advocates? And now I'm happy to say we have what's called the Purple Ribbon Project, and they have certified IPV advocates who work their day-to-day job, but are also certified to support someone and just helping to make that warm referral to our services. And we meet with them on a quarterly basis. I just met with them today actually to talk through their struggles, things they could use to help better support their patients. So it helps both of us, and it's been an amazing collaboration to help turn around issues with documentation, issues with buy-in, all these different things. So it's kind of just kept that relationship going.
Thank you, Ashley. Melinda, I have a question for you. So what we've learned over the years, and what Blue Shield actually published several years ago, was information that indicated that 80% of patients who were asked about violence in the home by a provider said that they would feel comfortable in disclosing what it is that's going on at home to that provider if only they were asked, right? So here's my questions, very specific. How did you begin the work of establishing relationships with healthcare and healthcare providers to better serve domestic violence survivors in order to establish expertise for training? Because we have the facts, we have the studies, it's all there now. And sometimes providers or systems want us to skip over all of the facts and the trainings and just want us to come in and do the work, right? But they're not necessarily willing to let us in. Facts that we've taken 50 years now in researching and coming up with. So how did you begin? How our expertise is important. That was from Melinda.
Thank you. And I just want to say that you were freezing off and on, so I may not have caught everything, but I think I got the gist of it. And it's really what you offer, the value, the information, and the expertise that you have. And even though there are times when other entities, organizations, or stakeholders may say or think, oh no, we got this, we understand, we totally understand. We absolutely use not just data, but the newspaper, the headlines, to really help communicate and articulate the need for us to be working together and for us to be making sure that our communities are safer and to actually be making sure that people get to make decisions for themselves, because one of the most important things is making sure that you ask, support, and offer, but don't mandate.
So I'm going to flip that because I've been picking on providers, right? How do you motivate your staff? Or, I mean, I feel like sometimes 60% of my role within the organization is as a hype girl. I'm reminding the people, you are the expert in domestic violence. You are the expert in sexual assault. You've been doing this for, we have all of the facts. And so my hype girl skills have grown great because I find myself constantly, not constantly, but consistently having to remind the staff that they have every right to be in a room with medical professionals who have medical degrees that come from very prestigious schools. And we have the opportunity to educate them. And sometimes that is very intimidating, especially if you come from a system that is not supported. If you are a person of color, right, or if you're a minority of any sort, and you're walking into this room of privileged people, it can be difficult. So how do you hype your staff up? How do you get your staff in that room to do these trainings when they're looking at white coats all across the room? And those white coats are challenging, first of all, their very right to be there. And second of all, their knowledge.
Do you want me to answer that?
Anyway. I would like from all three of you would be great.
Yes. So I'll just start since my mic is off. Thank you, Amanda and Ashley. Really, I do that exact same thing. It's about you have the experience, you have the knowledge, and you're gonna always have somebody who says, "For real, I don't think so. That's not what I know." And you can absolutely say, no, here are the stats to back it up. Here's the information that I have, and here are the human stories, the real stories of people who did not get what they need from you. So let's help you. Let's all work together so that folks can get what they need and so deserve. And all the room, right? Latina girl walking in the room. I'm just gonna bring all my ancestors with me, and we're gonna do this.
That's great. Thank you, Melinda. Amanda, thoughts?
Melinda, I adored your answer there. I think definitely in all fields, but particularly in medical fields, and even, frankly, the DV advocacy field too, there are the voices that are loudest are the voices of privilege, right? White, cisgender, heterosexual voices often get lifted to the front. And so it is a challenge. That imposter syndrome is always a challenge. But I think what Melinda said was so true, is like, root yourself in stories, root yourself in the work that we do with clients and the lives that we see impacted by these very real conversations, by service providers, by healthcare providers, and root yourself in facts. To name one issue, is one of my bread and butter issues when I talk about this is the inclusion of the sexual health needs of LGBTQ survivors in conversations around reproductive and sexual health coercion. And as a response, providing as advocates, as medical care providers, stigma-free, accurate health information proactively with survivors so they can navigate their healthcare and safety. And so going into rooms with medical care professionals or going to rooms with DV advocates who very much like this is their bread and butter and they have a way of doing things, root yourselves in stories and facts. As we know that folks living with HIV experience IPV at higher rates. We know that folks experiencing IPV are more likely to contract HIV. We know that folks living with HIV who are in an abusive relationship are less likely to be able to follow medical care procedures and practices that they need for their health because abusive relationships are so chaotic. Root yourself in those statistics, root yourself in those facts and those stories, and the people in that room who are coming there from a standpoint of being a domestic violence service provider, they care about survivors, a healthcare service provider, they care about people's health and well-being. They hear that, and the facts speak for themselves, the stories speak for themselves, and then we can move on to skills building, right? We can move on to best practices, and we can move on together.
Thank you. Ashley, did you want to?
Sure. Yeah, this is a great point to bring up. And I'm just the same as all of you have said. Like, I basically tell my staff here that I'm a cheerleader for our hotline. I go out every day just trying to like really hype up that this is a resource for you. Because what I try to tell our advocates is it doesn't feel great when you feel like you don't know how to do something. And sometimes that might be how a medical provider is putting that towards you. It's saying, questioning you, things like that. But just as we don't know how to cure certain medical diseases, they might not know how to support a victim survivor. So standing there and offering those supports and letting them know, hey, you don't have to be an expert. This is why we're here, and let you do your job and we'll do ours, I think can really help people feel better about it. And then the last thing we always do is we always challenge people to put up our tear-offs in the bathroom, because every day I get told, we don't really have IPD here. It doesn't affect our population. So I say, can you please put up these tear-offs? And then without fail, within a week, I get a call, oh, we're going to need more tear-offs. So really trying to visualize and put a face to like what this is, and not keeping it as silent as it usually is. So I think those have all been really helpful for us.
Thank you so much. Amanda, I have a question for you. How does the LGBTQ Center utilize training and education to decrease the barriers in survivors that you work with?
Yeah, thank you so much for this question. We deliver state-of-the-art training and technical assistance that expands the capacity of public and private agencies of all sorts to provide culturally responsive, survivor-centered LGBTQ intervention and prevention services. So we don't want a service provider, the survivor leaving a service provider after experiencing bias, being incorrectly assumed to be the abuser because of their gender identity or expression, right? A lot of organizations, police responses, DV service providers, medical care providers look at survivors and make an assumption about who's an abuser just based off gender identity or expression. Being denied shelter because of their sexual orientation or gender identity, or asked invasive questions about their identity. We want instead survivors to always be able to, no matter where they go, be able to access service providers and medical care providers who are knowledgeable about the unique and specific barriers that LGBTQ survivors face and are equipped with the language and the skills to provide specialized and intentional support. So we provide training on that survivor abuser differentiation that goes off of dynamics of power and control rather than gender identity and expression. We provide training on language and terminology that's best practice to use. We provide technical assistance to shelters who are trying to come up with innovative strategies to shelter folks of all genders and sexual orientations within the limitations of funding and the space available. So we work with wherever folks are at to provide that specialized training and technical support. It can be one-on-one with an agency, so we can really do a deep dive. And we meet with agencies to talk about what sort of training topics and they want us to most focus on.
And then Amanda, I'm going to go. A lot of times, is around the mandates that are in place, right? So we have to fulfill an hour, and we have somebody come in from the LGBTQ Center to talk about this, and this in 1 hour. How would you go about expanding relationships with our organizations that do not focus on the LGBTQ community, or why is it valuable on those resources?
I'm so sorry, you're cutting out, so I couldn't get the exact question that you're asking. I was trying to pull the bits and pieces, but I don't think I have it. I'm so sorry.
Yeah, so I was asking, what is the value in all community-based organizations, expanding the training and our knowledge around the LGBTQ resources, and collaborations that should be happening more often than they do?
Yeah, I mean, there's tremendous value, as we know that LGBTQ folks experience IPV at higher rates and have disproportionately negative health outcomes. So whether you're looking at this from a health lens, a DV lens, an LGBTQ lens, we're all in this together. In that if we provide culturally responsive care that addresses the unique and specific needs of LGBTQ survivors' health, safety, and well-being is going to be enhanced. So sort of to answer your question a little bit more deeply, I would love to see as a starting point conversations between domestic violence service providers, LGBTQ social service providers, and healthcare providers, all having conversations and meetings and cross-training and dialogue would be a great starting point. But my dream scenario would be survivor comes into a clinic to receive healthcare. They disclose their LGBTQ. They disclose they're experiencing domestic violence from their partner. That healthcare provider is able to provide trauma-informed care that is responsive to their unique and specific needs. So maybe it's around HIV-related care. They're able to have a conversation about PrEP and PAP with information. And be able to connect them to a domestic violence service provider with a warm referral because they've had that connection and they know the people there and they have that cross-training and dialogue and collaboration. And same with an LGBTQ social service provider. They're able to say, hey, there's a support group at the LGBTQ Center you might be interested in. The LGBTQ Center offers an anti-violence program you might be interested in, right? They have that information and support. And same as when a survivor comes into a domestic violence agency and discloses their LGBTQ and discloses DV, that agency is similarly able to provide stigma-free information about PrEP and PAP in the same way that DV agencies are doing an awesome job about moving towards talking about birth control and STI testing and providing pregnancy tests and Plan B. They're able to provide information about PrEP and PEP and HIV antiretroviral therapy and more. And they're able to say, hey, there's a healthcare clinic we know because we've worked with that's LGBTQ inclusive and trauma informed, and here's their name, and here's that referral because they've created that partnership. So that would be my dream scenario. And I think that starts with conversations and collaboration and cross-training and dialogue. So we can move towards that dream reality.
Great, thank you. And I think we have time for one more question. And I think if I had one more question, the opportunity, I would, if I could learn from you one last thing, it would be to paint for me the image of what a true partnering, collaborative, survivor-centered response program, support program looks like at a medical center.
Is this for me? Is this for everyone?
You can start. Your mic's on, so if you want to go ahead and start.
It looks to me like those partnerships that I talked about existing, right, is that there is that community building and that relationship piece between the different stakeholders here that offers specialized support. I know that Ashley mentioned is like medical care professionals have a lot on their plate, and like we're trying to provide tools and resources and knowledge and expertise, but if we can share that expertise by all coming to the table together and having those partnerships, that's ideal. Trauma informed is that we don't have a survivor has to go to the right clinic at the right time and talk to the right medical care professional. They don't have to go to the right domestic violence organization and talk to the right advocate that's LGBTQ competent at the right time to get culturally responsive care. Is the idea is that there's no wrong door, and that, you know, whatever setting, whatever door that survivor is coming into, we are all working together to provide collaborative care that's making sure that their health specific needs are being addressed, that their safety specific needs are being addressed. And we're pooling in the experts from these different sectors to be able to work with that survivor, right? Is I can be the most awesome LGBTQ inclusive domestic violence advocate ever. And if a client comes in and needs access to PrEP, I can't actually prescribe that, right? We need to be working with healthcare clinics and be able to have that partnership so that we can refer with confidence to know that survivors can receive trauma-informed, stigma-free care. But there's a limit to what we can do from each of our standpoints.
Right. Thank you, Amanda. Melinda?
Mine is really simple. It looks like this. No matter who you are as a survivor, when you come in, when you walk out, you're going to tell your gente, you're going to tell your people because they treated you like you needed to and deserved to. That's what it looks like.
Thank you so much. That's powerful. Thank you. And Ashley, paint that picture for us.
So I would say one of my favorite resources that we've been able to do is really making sure that we have that survivor-centered collaboration by bringing like what I would consider as problem areas all together. So like we've all talked about here today, taking what we don't know and bringing those people to the table, or taking those people that seem to stand as barriers, like police officers, DCF. We have what's called community advisory boards, especially around pediatrics and IPV. Really bringing together people who don't necessarily think IPV affects their population because they're children. No, we know it does. And bringing police officers to the table, DCF to the table, letting them know what survivors think of them, and then DCF letting us know what their requirements are. How can we work around that? Letting pediatric providers know that when they're screening children for abuse, what they could be doing to support their parents right then and there by having an IPV advocate come on scene. So giving survivors a voice, but also learning from others as to what their requirements are and how we can best fit that information into their goals as well. So I think bringing everyone together, making those meetings, sitting down and hearing each other out, even if it ends in a little bit of a fight for a little bit. At the end of the day, we've been able to turn programs 180 on people's opinions of why IPV is so important. It's really been amazing to watch that.
Thank you so much. I want to thank you for being here with us today. I think that we've all taken a lot of information. A lot of your experience and knowledge has been really helpful to many of us here in this room, and then of course online virtually. This concludes our session for today. If you have any questions, I know that Virginia is still taking questions, and I can go on, I can hop on the chat and respond to them if necessary. We have Amanda, Melinda, and Ashley's contact information, which you can also reach out to them. And thanks again for being here and for all of your expertise. And thank you all for putting up with all of our IT